Hi, I'm Dick Kerr, Group Content Director of Urology Times and urologytimes.com. I'm speaking today with Mark Painter of PRS Network, a leader in the field of coding, reimbursement, and practice management tailored to urology and other medical specialties. Mark and Dr. Ray Painter are also the co-authors of the coding Q&A and coding and reimbursement columns in Urology Times. We're talking with Mark today about a topic that's very much on the minds of many urologists, and that's how to get the most out of selling your practice to a hospital. There are certainly many important aspects of evaluating a sale to a hospital system, including making sure the physician's values align with that of the hospital. Our discussion today will focus on reimbursement specifically. Mark, please start by telling us what is unique or different about contracting with a hospital system.
All right. For a lot of physicians and urologists in general, they've been on their own or in private practice for a long time or in a group setting. But mostly they've been fairly small groups. So one of the things that's a big issue in moving from a more of a private practice base into a hospital-based employment setting is the fact that you're moving from really a place where you're guiding your own ship to moving more or less towards a place where you're becoming an employee of a larger group where you are part of a larger system. So the urologist that's moving into that setting needs to understand that from a reimbursement perspective from what they do, they're going to lose a lot of their ancillary revenue. They're going to be really tied now to their production on just what they do in urology. And so when they look at that transition from where they are right now, where they may actually be deriving revenue from employees from radiation oncology or pathology, really their revenue then in the hospital setting is going to be driven solely on what they produce. So it's a bit of a change in some ways back to the way things used to be and just dealing with urology services only and not getting any money off that ancillary care.
Okay. With respect to reimbursement, what are some of the questions urologists should ask before entering into a contract with a hospital?
Okay. So there's a number of different things, and what we've seen to date are basically different stages in a contract. Obviously, you've got that first initial sale piece. The hospital is coming to you and purchasing usually stuff like your hard equipment. They may be depreciated. They're looking at maybe purchasing an electronic medical record from you. And they may be looking at taking over some of your hard costs like leases for buildings and those types of things. So there's some value in whatever you have in that hard asset. So that's one of the first things that they will look at. Now, the other piece of what you've developed in your practice or in urology practice really comes down to the goodwill and the service that you provide. And right now in this marketplace, there isn't, at least in many of the deals that we've seen lately, there isn't a lot of value placed on that patient base, especially in the smaller practices. Now, larger practices with an excellent patient base and some good contracts may actually come with a different value on the go forward. But the smaller urology group is really looking at their value in their hard assets and then in the value of work that they bring to the table in moving into a hospital-based urology practice. And the hospital drives revenue from not only what you do but the ancillaries, but then you're not, as a urologist, going to drive that same revenue. So you've got to look at the value of that contract, not only on that initial price, but also, and for most people, the real value is in that contract moving forward from that point.
Mhm. Okay, what types of databases are available to benchmark for contracting?
So right now, probably the best database we have access to, as far as looking at employed physicians, is the MGMA database. We've been looking for other databases, and I do think that there are some other surveys and things being done that could really take a look at collecting this information, like the American College of Physician Executives, maybe looking at some additional information. But right now, MGMA. And MGMA can give us a couple of different things. They can look at salaries, which is one of the ways physicians are contracted, or they can look at work RVU productivity-based contracts and ranges in the conversion factors.
Okay. What kind of leverage do urologists have when negotiating a hospital contract?
That's going to depend on where you are and what you're doing right now. You know, the value of a urologist is broader than just what that urologist produces. Obviously, there's a definite value in the urology care that any urologist provides, and that's really what they're buying. But there's also the ancillary revenue that comes from a urologist ordering things like pathology services, ordering imaging services, referring patients over to radiation oncology for things like IMRT or CyberKnife. There's also the revenue that's derived from a physician that takes their patients into the hospital setting and the facility that's there. So when you look at that overall value to the practice, that's really where it comes back into the revenue stream. So if your money or if your referral base or your referral pattern already drives those patients into the hospital system and they're relying on that revenue, you have some value to that hospital that may give you some leverage. The other side of the coin is kind of the complete opposite. If you're in the community and you've got all of that internally, or if you've got all that ancillary revenue that's going, excuse me, that's going to another hospital system, now you've got some leverage in between maybe two hospital systems in your marketplace that you can use. So it's going to depend on where you're positioned, what services you currently deal with in or with that hospital that you're talking about being employed with. Are there other hospitals in the marketplace that are also looking at hiring you? They're also going to look at your position overall relative to the market. If you're the solo guy and there's a big urology practice down the street, and you're eventually and the thought process of the hospital there is, you're either going to have to join them or join us. You may have a little different type of leverage. So everybody's leverage is really based on their marketplace. It's from region to region, but you do want to take a good look at those things. Now, from a global perspective, I think urology does have some significant leverage in that there's only so many urologists out there. And everybody knows that we've got this big bubble of baby boomers coming up, and all these folks are going to need urology services. Well, maybe not all of them, but a vast majority of them are eventually going to need urology services. So if a hospital employment group is really going to make themselves available as a network in a marketplace, they've got to have a urologist. So although your leverage varies and sometimes you can feel like you have none, you always have some leverage. And part of that leverage, I think, on the other side, if you look at it from the urologist perspective, is what are you willing to do? What are you willing to walk away from? Are you willing to walk away completely from that area? So that tie to where you are versus that mix of where you are in the marketplace, all of those things affect what your leverage is. And you need to look at all of them.
That makes sense. Let me ask you this: if a urologist receives a lucrative contract, a lucrative offer initially from a hospital that shifts to being based on productivity after a period such as 2 years, how does the urologist determine what will happen after that 2 year period?
That's a great question, and right now I think that we're seeing this as a struggle for a number of our urologists who are approaching the second year of their contract where they had a salary or a hospital guarantee. And that does seem to be a pattern we've seen in the marketplace. Maybe you get a 2 year salary or a 3 year or a 4 year salary, and then you immediately move at that point in time to a productivity-based model. So one of the early mistakes that we saw with a lot of folks was taking a look at work RVUs, and that's what a lot of the productivity-based contracts are based on, is the number of billed and collected work RVUs. If they take a look at where they are right now in the marketplace, a lot of the urologists, they may see that their work RVU production is in the 9,000, 10,000, 12,000 range per year. But what they need to really take a look at as they move into a hospital system is that things like radiologic services, pathology, lab, any RVUs that are generated from services that are not directly generated by their work or that small incident 2 set of work that's out there, that needs to be subtracted out. And so what you're looking at down the road is, if my practice stays as busy as I am right now, and if I subtract out all my ancillary work RVU, what is my actual RVU at this point in time? And at that point, you've got at least a working set. Now, the other thing we've unfortunately found is that a lot of the hospital billing systems aren't really geared towards maximum collections for a physician. So I would take where I am right now. I would subtract out everything that I have as far as my ancillary services, and then I would take another maybe 5 to 10% off of my work RVUs just from lost revenue and potential lost production in that hospital setting, and then I would multiply it by a currently available MGMA conversion factor, say somewhere around $55, and I would shoot on the lower end for those types of things, and see where that brought me as far as a reimbursement number for the year, a salary. So $55 times as many work RVUs after I ran my calculation, and that's probably what I'm looking at once I step off that salary issue. So I think those are all things to take into account as you move into those settings.
How does a urologist evaluate a hospital's billing department?
The best way we've found so far to evaluate that is to actually look at what they're doing. And now you may not have that opportunity. And obviously with a lot of urologists, when they're stepping into that, what we have the advantage of as a consultant group going in to help physicians on these types of negotiations is we can actually look at some past history of how they've done with other urologists. If you got that aspect, if you can get to that, you can talk to other urologists or look at what is billed and collected and the adjustment reports that the hospital generates for a urologist. That's the best tool you've got, because that gives you an idea of how they deal with urology. They don't have urologists. I would look at how they deal with other specialties, and specifically look at maybe a little more closely related specialty, maybe not anatomically, but kind of that office procedure mix, like an ENT or an orthopod, and see where those folks are in their collections. And I talk to the other physicians in the group. How many things do they feel are being written off because there's not follow-up? So talking to the other physicians that are already in the network and looking at data, if you can get it, as far as collections versus charges and adjustment reports. Now, the other thing you'll need as a baseline to figure out whether or not that makes sense is where is their fee schedule. So what are their charges relative to current Medicare rates, so that you can get a kind of a feel for where that sits.
All right. Mark, thank you very much for your valuable insights and your practical advice today. For more coding and reimbursement advice from Mark and Dr. Ray Painter, please visit urologytimes.com. And to learn more about how the specialty of urology is being impacted by hospital employment, see the May issue of Urology Times.